Hello, this is Stephen Holloway. Today we'll be discussing Nursing 202, Module E, Acute Kidney Injury. Acute kidney injury used to be known as acute kidney failure, is a rapid decrease in kidney function leading to the collection of metabolic waste in the body. Now, AKI, or acute kidney injury, can result from three different pathologies as we'll look at it: pre-renal, intrarenal, and post-renal. And we'll look at these in depth as we progress through this lecture. But when we're talking about these three types of things, anything that reduces blood flow to the kidneys, hypoperfusion to the kidneys, is called pre-renal acute kidney injury. Damage to the glomerular, interstitial tissues, tubules, is called intrarenal or intrinsic acute kidney injury. Or post-renal is caused by an obstruction of the urine flow. Anything coming out from the kidneys down through the ureters to the bladder to the urethra can cause post-renal acute renal injuries. When we look at these patients, healthcare-acquired AKI occurs in as many as 4% of hospital admissions and up to 20% of critical care admissions. Most of these episodes are due to events that lead to hypotension with poor kidney perfusion or hypoperfusion of the kidneys, and causes worsening kidney problems. For patients who survive the precipitating event, the chance of return of kidney function is good. However, complications during the course of AKI can greatly increase the risk for death. One of the things that we see can greatly increase the risk for death are bloodstream infections from contaminated IV lines, such as central lines. This is the reason many hospitals have gone to special teams doing the care of central lines in their facilities. What we see is the highest death rate actually comes from trauma. Up to 70% of the patients who have renal trauma will end up dying because of that issues. The other prognosis, as we begin to look at it, in AKA caused by nephrotoxic substances has the lowest rate of recovery, and the prognosis for acute kidney injury caused by obstruction or glomerulonephritis is actually a little better than that. When we look at the history of these patients, we'll talk about this a little bit more in depth, but when we talk about pre-renal, really what we're looking at is anything that can decrease the blood flow to the kidneys. It could be as simple as from someone that's dehydrated, not drinking enough fluids, heat exhaustion, heart failure, diuretic use. Bowel preps in our older generations can actually cause these types of issues. Intrarenal, when we look at it, medications, whether it be prescription, over the counter, herbal, or illegal medications can do those type things. Also look at the work history when we're talking about intrarenal type patients. Are these patients in contact with nephrotoxic agents? Some of the organophosphates, some of the heavy metals in their work. Now, post-renal, as we're taking the history on these patients, we're going to ask them about any history of stones, any change in urine flow, any history of BPH or malignancies. Are they having any urgency or nocturia? All of those are things that we'll look at with these patients as we begin to look at each of these processes as we move along. Now, pre-renal AKI, or acute kidney injury, is defined as pre-renal, or you may hear it called pre-renal azotemia. Azotemia meaning a buildup of nitrogenous waste in the blood system. But pre-renal azotemia is kidney injury caused by poor blood flow to the kidneys. The most common problems leading to acute kidney injury are hypovolemic shock and heart failure. Reversible pre-renal azotemia may occur after any episode of acute hypotension, hemorrhage, shock, burns, or heart failure, or any problem which the blood volume is depleted, leading to hypoperfusion of the kidneys. And again, we talked about earlier on, in our older population, extensive bowel preparations, being NPO before surgery without any fluid replacements, fluid loss during surgery, can all lead to these prerenal acute kidney injuries in some patients. Table 73.1 will give you the list of some of the conditions that cause prerenal, intrarenal, and postrenal kidney injuries. When we look at table 73.1, the big things that we see, of course, are the ones we talked about. Shock, whether it be hypovolemic, hemorrhagic, distributive, or obstructive shock, heart failure, pulmonary embolism, anaphylaxis, sepsis, or pericardial tamponade. Any of those can lead to hypoperfusion of the kidneys, which can lead to damage to the glomerula and to the nephrons of the kidneys due to ischemia. And it's that prerenal, it's that ischemia that is the cause of the problems with these patients. What we see in these patients is basically with shock or with reduced blood flow or reduced circulating volume, is that the kidneys begin to try to compensate by constricting renal blood vessels. And part of this process is then activating the renin-angiotensin-aldosterone pathways, which leads to, and by releasing antidiuretic hormone. All these responses are to help increase blood volume and improve kidney perfusion. However, these also begin to cause reductions in urine volume, which results in oliguria, again, a urine output less than 400 milliliters a day. And because of the oliguria, those type of things will begin to develop azotemia, the retention and buildup of nitrogenous waste in the blood cells. Because of this lack of flow, blood flow, all of this going on, nephron cell injury is likely to occur from the lack of oxygen to them. And with that then reduced blood flow, there's reduced filtration. So it's a circulating pathway. Toxins can cause blood vessel constrictions to the kidneys, again leading to reduced kidney blood flow and kidney ischemia. So as we look at this, it's really the hypoperfusion process that's going on. Now, we as nurses have a great responsibility in monitoring our patients, especially if we look at critical care. As we saw, 20% of our patients in critical care can develop acute kidney injury as part of their state. So very important that we're monitoring these patients, their vital signs, looking at their urine output, looking at their intake, monitoring if we have a CVP or a PA catheter in place, monitoring, looking for hypotension, looking at their lungs, listening to their lungs, those type things. Now, your book says this, and so just so you know it, nurses have an essential role in the prevention of acute kidney injury in hospitalized patients. Always be on the lookout for signs of reduced kidney function through careful physical assessment, especially of urine output and weight. Closely monitor laboratory values and the evaluation of fluid status. Early recognition and correction of problems causing reduced kidney blood flow usually restores function before tissue damage can occur. Evaluate the patient's fluid status, accurately measure intake and output, and check body weight to identify changes in fluid balance. So important that we are constantly assessing our patients. We're not just looking at that vital sign. We take an 8 o'clock vital sign. We don't just look at that 8 o'clock vital sign. We look at trends. How has it been responding over the last 24 hours? How does it that? Same thing with that urine output. Not just looking at that 1 hour of urinary output. How is it trending when we look at those? Same thing with daily weights. We're looking at trends. And that's how we identify problems, by looking at those trends in those patients. Don't think of your hourly vital signs as just something I have to get done. That gives you a picture of that patient as we're looking at it. Now, these patients, as we're beginning to try to treat them, probably are going to require a CVP line or a pulmonary artery catheter to help us manage the treatment of these patients, because treatment, we're going to talk about a little bit more as we get into the area. These patients are going to require fluid challenges to help get them back to those. We're going to look at treatment kind of as we look at all of them together. But management of these patients is really going to be that fluid status, trying to restore perfusion to the kidneys by increasing that fluid status. And as we talk about that fluid status, what you may see are fluid challenges to these patients. Being given a bolus of 500 to 1,000 milliliters of normal saline over 1 hour. What we should see with that fluid bolus, if they're in the early stages of this process, we should see urine output related to that fluid bolus and some changes in their blood pressures, maybe an improvement in their blood pressure and a decrease in their heart rate because we're replenishing that fluid volume. You may see loop diuretics used in these patients, but that won't occur if this patient is in the oliguric phase of acute kidney injury. At times you may see dopamine used. Be careful with dopamine. Dopamine has 3 different levels of working within the body. When we start talking dopamine, the very lower levels is what's called a renal dose. And a renal dose basically causes an improvement in the renal blood flow. Now, using dopamine to raise blood pressure or any of the other medications to help raise blood pressure do not work unless we have adequate fluid volume. Replacing fluid volume in hypotension or in as we look at these patients who are hypovolemic, fluid has to replace first before any of the pressor agents will properly work. So what you will see first is fluid challenges to these patients, giving them fluid, trying to get their fluid level back up, whether it be things such as normal saline, Ringer's lactate, albumin, or even blood if it's a hemorrhagic type shock, to get them back up, get that fluid status back up to par. Again, the pressor agents will not work in these patients if we don't have that fluid volume reestablished. Now, as we look at intrarenal acute kidney injury, we're going to look at the etiology, the pathophysiology, clinical manifestations, assessment, and those. But the term intrarenal acute kidney injury is often referred to as oliguric acute kidney injury in the clinical settings. Causes can be infections, whether it be bacterial, viral, fungal, can be from drugs, especially aminoglycosides, certain antibiotics, and NSAIDs can cause those problems. Invading tumors such as lymphomas can cause problems, leukemia, all can cause acute interstitial nephritis. Other causes of acute kidney injury include inflammation of glomerula. In other words, we talked about glomerulonephritis can lead to that. Or small vessels of the kidneys can be inflamed, vasculitis, or an obstruction of blood flow to the kidneys, such as some of the stenosis that we have talked about. Actual physical, chemical, what happens with these patients is we see changes going on due to physical, chemical, hypoxic, or immunological changes directly to the tissue of the kidneys. Again, Table 71-5 talks to you about the different problems: acute interstitial nephritis, exposure to nephrotoxins, and Table 71-5 has a good look at some of the different nephrotoxins, heavy metals, antibiotics, other medications can cause some of these problems. Look at those, be familiar with some of those. Vasculitis we talked about, acute tubular necrosis, renal artery or vein stenosis, renal artery or vein thrombosis, formation of crystals or precipitates in the nephron tubules. Even looking at those, remember with glomerulonephritis, those immune complements clogging those areas can lead to this intrarenal or intrinsic kidney injury. What happens is the kidney tissue becomes inflamed because of the infections, drugs, cancers, and it results in that immune-mediated changes in the kidneys. With this extensive tubular damage, the tubular cells slough and combine with other formed elements such as red blood cells and form casts. And these casts can cause problems within the tubular lumens. Not a problem with outflow of urine, but in that whole filtration process from there. So you can see problems in that. Clinical manifestations or intrarenal AKI usually occurs with damage to the glomerular interstitial tissues and tubules. These manifestations are related to the retention of fluid and nitrogenous wastes in the body. These include oliguria, a decrease in urine output, or anuria, an absence of urine output, edema, hypertension, tachycardia, shortness of breath, distended neck veins, elevated CVP, central venous pressure, weight gain, You may hear respiratory crackles. These patients may be anorexic, may have nausea and vomiting, and may be lethargic and have changes in the level of consciousness. Manifestations of electrolyte imbalances, particularly elevated potassium levels and low calcium levels, can be there. Because of those, we'll see changes in the EKGs of these patients. Management, assessment, again, good physical assessment, looking at your intake and output. We're going to be doing our assessments. If we're seeing any signs of fluid retention in these patients, the dependent edemas. Remember, if a patient is bedridden, though, the dependent edema is not going to be in the lower extremities, but it's going to be more in the areas that are closest to the bed, typically in the pelvic areas for these patients. We're monitoring their blood pressures. We're listening to their lungs. We're listening for changes in lung sounds. We're listening for an S3 that could indicate can indicate fluid overload in these patients. We're also watching their labs, watching that EKG. Are we seeing a spiked T wave related to that elevated potassium levels? Are we seeing dysrhythmias related to that problems? Are we seeing changes in the conduction system related to the calcium levels? All of those can indicate problems that's going on with these patients. So a good assessment, again, as we see our patients, we're not looking at them at a single point in time. We're trending the care in these patients. Management of these patients is going to depend on the origin of the damage to the kidneys. If it's an infection, we're going to start antibiotics on these patients. But even if we start antibiotics, we still need to monitor that renal function, because remember, antibiotics can cause problems with the kidneys themselves. If it's related to an immunological, we may need to treat them as we did some of these others with corticosteroids. It all depends on what's going on. The management is going to be dependent on the cause of this intrarenal injury with these patients. Now, post-renal is kind of the most simple when we look at it. When we look at the etiology, when we define post-renal, and then we'll look, it kind of goes along with the etiology. Post-renal, basically, obstruction of the urine collecting system anywhere from the calyces to the urethral meatus can cause problems with post-renal failure. What we're having is basically that backup of fluid back up into the kidneys. When that pressure in the kidney tubules, the intrarenal pressure, exceeds the glomerular pressure, glomerular filtration stops. This problem allows nitrogenous waste to begin to collect in the blood, increasing the BUN and serum creatinine levels. Now, one thing to note, that basically with post-renal acute kidney injury, there has to be a blockage in both the ureters, or a bilateral blockage of the ureters, to really cause post-renal failure, unless that patient only has one kidney. So, but most of the time, if we're seeing this, we're seeing bilateral type issues. Typically, if a patient has two functioning kidneys, has a blockage of a stone in one ureter, the other kidney is going to take over and function and remove the nitrogenous waste. But if we get blockage in both of them, then that backup and that inability to filter the nitrogenous waste will put these patients into acute kidney injury in these patients. Some of the causes: ureter, bladder, and urethral cancers, kidney, ureter, or bladder stones, bladder atony. In other words, the bladder does not have the muscle tone anymore to empty, so we've got a backup of urine in the bladder. Prostatic hyperplasia, or cancer of the prostate, urethral strictures, and cervical cancer can lead to all of these type processes. The clinical manifestations on these patients are similar to what we see with the other patients because of the lack of removal of fluid and the buildup of nitrogenous waste in these patients. So we'll see all the other clinical manifestations. You can see that in chart 71-1. Assessment for these patients post-renal: basically we're going to be monitoring for oliguria or intermittent anuria, looking for symptoms of uremia and lethargy on these patients. We're going to be reporting any changes early, looking at these patients. If we know they have a history of stones, some of these are a problem, asking about changes in the urine stream, difficulty starting the urine, and the presence of blood in their urine. Management basically is remove that blockage, whether it be through open surgery, through basket removal of stone, through lithotripsy, those type of things, trying to remove that. If it's strictures, putting in a stent, maybe going in and rerouting the ureters, whatever is, wherever the blockage is removing that blockage from the patient as we look at these patients. Now, as we look at acute kidney injury, there is a system that has been derived that's called the RIFLE, R-I-F-L-E, classification system. You will see that chart on it's in your book. It's chart 72 or 71-2, and it lists the classifications of acute kidney injury based on 5 RIFLE categories, and these are changes in glomerular filtration, serum creatinine levels, and reduction of urine output. The RIFLE stands for risk, injury, failure, loss, and end-stage kidney disease. These criteria apply to patients with no known kidney problems and to patients who have chronic kidney disease, such as who have had diminishing output or diminishing renal function, as evidenced by increasing BUN and creatinine. The first 3 of these criteria, the RIF, are injury severity levels. Identification of acute kidney injury at any of these levels and then proper management can prevent progression into a non-reversible state. So if we identify the patient in the R, I, or F categories and we provide treatment to these patients, typically we're going to get a return of kidney function. Now, that kidney function may not go back to the normal that the patient had before, but you may see kidney function that is enough to allow them to proceed with a normal life. So, there goes back to us as nurses being astute to what's going on with their patient, making sure we understand what's going on. If we see a patient that we've been seeing their serum creatinine levels going up, and we see an increase of 1.5 times above the normal or the patient's normal. As I have talked about many times, my wife has had a kidney transplant. Her normal creatinine level is running about 1.5. So if I'm looking for acute kidney injury for her, I am not going to be looking at a 1.2, which is high normal. I'd be looking at her normal 1.5. So if I see a 1.5 time increase in her creatinine level, I'm beginning to get concerned. Now, I'm not going to wait till it gets to that 1.5 times above normal. I'm monitoring what her creatinine is doing routinely. For my clinical group, when we go to clinicals, I tell you to trend your labs. This is what we're looking at. Is it going up? Is it going down? And as we begin to see treatment of these patients, when we look at treatment, what we're doing is looking and seeing if we're seeing that creatinine and BUN going down in these patients. The other thing we see that these patients are at risk for developing problems, a decrease by at least 25% of the patient's normal glomerular filtration rate. Again, you can get that in the lab values as you look at your labs, but that's something you'll be looking at on a daily basis. Then you're going to be looking at their urine output. If this patient has had a urine output of less than 0.5 milliliters per kilogram hourly for 6 hours, then that's a notification. A notification to you as a nurse, hey, that something's going on. Again, we talked about trending as an issue for these patients. If we see that and this patient then bumps up to their serum creatinine 2.5 times their normal, followed by a decrease in their GFR to 50%, and then that 0.5 milliliter per kilogram per hourly urine output for 12 hours, this patient is a greater risk. There's probably some injury going on at this point in time. So we really haven't provided treatment, or our treatment has not been effective in this patient. Again, we're going to continue monitoring, we're going to continue our treatment to try to go ahead and stop this progression and move forward with this patient. The F, the failure, we see an increase in the serum creatinine levels 3 times the normal standards, a decrease by 50% of the glomerular filtration rate, and now we're seeing basically less than 0.5 milliliters per kilogram hourly for 24 hours, or no urine output anuria for 12 hours. This patient now is in true acute renal failure at this time. So this patient's typically going to require treatment with dialysis or some type of kidney replacement therapy. Again, most of the time this is going to be short term, but it has to happen. If we get a patient that is in the L or E levels, these patients are very serious. They're going to require renal replacement therapy, hemodialysis, some of the other type of continuous renal replacement therapies for a period of time. Hopefully, again, we can reverse these patients. If they get down into E stage, end stage kidney disease, we may not save the renal function. These patients may end up going into or are in end stage renal disease and may have to be on dialysis for the rest of their lives. So you can see these are just ways of us knowing where that patient is and knowing what's going on with our patient. Again, we talk about trending. It's the responsibility of all healthcare professionals to be alert to the possibility of acute kidney injury. We need to be alert. We see problems. We need to implement strategies and then identify needs to implement appropriate interventions to prevent permanent impairment of kidney function. Our goal is to prevent that permanent kidney function on these patients. Now, if these patients do move into acute kidney injuries, there's stages it goes through. This is from your book, and I'm sorry I did not write down what chart this was, but this looks at the phases and the descriptions of acute kidney injury. You have your onset, your oliguric, your diuretic, and your recovery phases, and each is characterized by different types of processes. That onset would probably then kind of go along with the R and the with the R or maybe even the I processes of the rifle assessment as we look at it. But onset begins with a precipitating event and continues until the oliguria develops. It's going to last for hours to days. But what we're seeing is a gradual accumulation of nitrogenous waste, and that's measured by looking at your serum creatinine and BUN levels. Now remember, when you look at your labs, you also have a BUN creatinine ratio. When you see that total ratio going up on these patients, that means both the BUN and creatinine are going up. We're seeing those go up, so we're looking at kidney damage on these patients. These patients will move from that onset phase into the oliguric phase, which is characterized by a urine output of 100 to 400 milliliters in a 24-hour period. And what happens in this oliguric phase, these patients will not respond to a fluid challenge. So if we give them a liter of normal saline over an hour, as we talked about, what's happening is basically it's staying in the system. We're not seeing it put out as urine. So if you have a physician that orders a fluid bolus, you do it, you've got to monitor that urine output and see what's going on with that. During this time frame, we're seeing an increase in serum creatinine and BUN levels. We're seeing hyperkalemia. We're seeing metabolic acidosis, hyperphosphatemia, hypocalcemia, hypermagnesemia. That one's hard for me to say, but an elevated magnesium level. We may see sodium retention in these patients, but it may be masked by the fluid retention, giving a dilutional effect on these patients. We may see basically urine indices are typically low, so we're going to see dilute urine that is coming out. So you're going to see all of those type things going on. The oliguric phase usually lasts for 1 to 3 weeks. The patient will move from that period of minimal urine output to almost no urine output into a diuretic phase. All of a sudden, this patient will start putting out tons of urine. You can see up to 10 liters per day of dilute urine in these patients as they move into the diuretic phase. So that can occur anywhere from 2 to 6 weeks after the initial injury to the kidneys. It increases rapidly, and it goes on for over a period of several days. Our big problem here is electrolyte loss typically precedes loss of the nitrogenous waste, so we have to be aware of problems with electrolyte losses. If we're seeing too much sodium loss, we can see problems with encephalopathy. We can see hypokalemia. We can see the problems that go along with the cardiac with those. So, but later what's going to happen, we're going to begin seeing that BUN and creatinine levels fall till they reach that near normal plateau. They may go back to normal, or they may stabilize at an area a little bit above normal if there has been damage to the kidneys at that point in time. Patient then moves into a recovery phase. This can last up to 12 months, but it's just a chance to give that patient time to recover back to it. Again, they may never reach pre-illness levels, but they may have enough kidney function that's sufficient for a long lifetime process. Now, just a couple of things to remind you of, that during that oliguric phase, our care is going to be focused on monitoring for life-threatening electrolyte changes and nitrogen retention in these patients. During the diuretic phase, we need to be watching for hypovolemia and electrolyte losses are the kind of the main problems. During that diuretic phase, we need a plan of care that focuses on fluid and electrolyte replacement for these patients. Nutrition of these patients who are in acute kidney injury is going to be based on whether they have to have dialysis or not have dialysis. We do want to make sure we're watching their protein in these patients. If they do not have to have dialysis, they need to be getting 0.6 grams per kilogram of protein a day. If they're on dialysis, they need more protein, 1 to 1.5 grams per kilograms per day. Sodium needed 60 to 90 milliequivalents a day, potassium 60 to 70. Fluid, as in chronic kidney failure, as other types of failure, our fluid is basically going to be our urine output plus approximately 500 milliliters. Some will say 5 to 6, some will say 6 to 7, but about 500 milliliters additional fluid with those patients. Sometimes because of that nausea, vomiting, the anorexia that goes along with these patients, TPN may be used to give them the nutritional status they need. Pharmacy will monitor this TPN. They will come in and review the patient's electrolytes, serum albumins, all of those to determine what type of TPN needs to be hanging in these patients. Our job is just to make sure we continue doing that. Remember that if TPN has a very high glucose content, we can't just stop that TPN. If we just stop that TPN, then we can actually put that patient into jeopardy of hypoglycemia and those things. One thing that will happen with these patients in acute kidney injury is the TPN, a lot of times, instead of having a high glucose content, will have a higher fat emulsion or intralipid. These intralipids can provide a non-protein source of calories in these uremic patients, and that's just to kind of avoid that glucose problem and excess sugar on these patients. These patients may require dialysis, hemodialysis. Sometimes they will use peritoneal dialysis on these patients if it's going to be longer term. But most of the time for these acute injury patients, you may see continuous renal replacement therapies, or CRRTs. Some of the CRRTs that you may see is continuous veno-venous hemofiltration, continuous veno-venous hemodiafiltration, continuous arterial-venous hemofiltration, and continuous arterial-venous hemofiltration with dialysis. The one that you tend to see most is the excuse me a moment, let me check my notes. Sorry, the most common type that you typically see is the CVVHD, or the continuous veno-venous hemodiafiltration type process. It's common because it uses an infusion pump, a hemodialysis membrane, and a diacylate solution, as well as the same type of blood access as for any of these other type problems. it needs to be performed for a longer period of time than one that uses an arterial site. But because it takes longer, the removal is slower, so we see fewer adverse changes in blood volume and blood pressure in these patients. They tend to tolerate it better, especially if these patients have been ones that have had hypovolemia as part of this process. Now, typically these patients, if they're going to be on this CRRT for a while, there will be a catheter placed, typically subclavian or intrajugular, internal jugular catheters placed. And these are used to do the dialysis or the CRRT for these patients. Typically, if they're going to have to go to long-term hemodialysis on these patients, then they'll start moving towards setting up the grafts on these patients. And we'll talk more about dialysis, grafts, those type of things as we go along. But typically, you're going to see these patients with something called an ash split catheter or some sort of 2 or 3 port catheters where they can do both blood in and blood out at the same time on these catheters to allow for this hemodialation, dialysis type process on these patients. So we'll talk more specifically about these patients, but it is, if you work in ICU, you may see these set up in the ICUs on these patients many times, especially if we're seeing a buildup of nitrogenous waste. These also can be used to remove chemicals from some of the, if we have some of the problem is related to a chemical with the intrarenal type processes. Your book has a table that looks at the ones that are dialyzable, and we'll talk about that more as we move into talking about dialysis. I hope you have a good day. If you have any questions, you can email me, and we'll try to talk about those. Have a great day.